We're going to talk briefly about health equity in general, which I think is something you're familiar with, but we want to give you a little bit of context. We're going to talk to you a bit about testing, especially rapid testing, because that's a big focus of our presentation. We're going to walk you through the 4 key points of our commentary that we published last month. That the short title is "It's Wrong Not to Test," because we wanted to make it really obvious. And then we're going to have a chance to answer your questions. So when we think about health equity, you may have heard of Dr. Paul Farmer, who is one of the co-founders of Partners in Health, and he's also a physician and is a professor at Harvard Medical School. And this idea of failures of imagination has really been a hallmark of the pandemic. And the fact that, as you know from your working with populations who are incarcerated, right, that there's a serious lack of imagination around how to provide basic human rights and ensure the basic human rights of people who are in vulnerable positions and are often unable to advocate or provide resources for themselves. So part of the framing that we have around this is the fact that the resources do exist and that there can actually be changes that can really help to empower and enable access to the kinds of interventions we're talking with you about today. And actually, it's not just something we think is true, we know is true from the history of a lot of great examples where we have been able to overcome these barriers. So just to give you a sense of what these barriers have looked like, the kinds of challenges that we're facing with COVID right now are not new, unfortunately. This happened as well with the HIV/AIDS pandemic or epidemic. And at the time, we have some representative quotes here from the leading experts on, resource allocation and health interventions. And basically, they thought, well, antiretroviral treatment is just too expensive, and people in Africa don't know how to use clocks, or wherever they were talking about. So I don't think they can take these pills the number of times they need to take them. And looking at this, these are not quotes that were said in private. This was public discourse around these topics. And so in the face of that, just to provide one example, this is just an illustration from Partners in Health. They basically said, this is ridiculous. We need to do something about this. And so they helped expand access to antiretrovirals. And this is just showing what happened in Haiti, where over time, these little green bars represent the increase in access to antiretrovirals to treat HIV. And then in red, this line you see going down is the fact that AIDS-related deaths went down over the time period shown. So they not only showed that it was possible, they showed that it needed to be done, and they did it. And that's basically what we want to talk to you about today in the context of COVID-19. So in order to make that part of the conversation make sense, I just want to go through a couple of slides that have to do with just the basics of testing, because we know from national poll data collected by the COVID Collaborative last year that kind of grabbed data from Americans from around the country that only like 30% or so are really familiar with what rapid tests are. So, statistically speaking, there's several of you probably here who don't know too much about them yet, and that's totally fine. So we just want to start you from the beginning. And so what I'm showing you here is that there are a couple of different categories of tests, broadly speaking. And so we have diagnostic tests, which include the kinds of molecular tests, PCR tests. You've probably been hearing about those in the news. And they're often used by medical professionals to actually help diagnose. So they're very, very, very good tests. They work really well. We also have other tests that, are kind of in the category of rapid tests. They can be very good. They can be used for medical purposes, but they can also be really useful for other purposes, like screening people or surveillance. And there are a couple of other types of tests that are done. We focus on rapid antigen tests, which I'll talk about a little more. There are other kinds of tests that can also figure out if you have people who have COVID-19 around, like wastewater testing. And one of our experts who's here today, Jeremy Rossman, Dr. Jeremy Rossman has a lot of experience with that as well. So he could answer questions about some other kinds of ways to figure out if populations have COVID-19. So also keeping track of time, because I know we don't have too much time. So there's been a lot of focus on the diagnostics side of things. And for FDA purposes, this has been a big roadblock because they've been trying to look at everything like it's a medical diagnostic test, when what we really need is to be able to screen people and to do surveillance. And so I have a little green box around surveillance because it may be possible to use rapid tests for a strategy called surveillance so that we can expand access even while we wait for FDA approvals. So there are a couple of kinds of COVID tests. And one category of these tests will tell you if you actively have the virus SARS-CoV-2. And so we have nucleic acid tests like the PCR tests and the molecular tests that I was talking about. We also have these antigen tests. So the molecular tests look for the nucleic acids that are inside the virus. The antigen tests look for proteins. And then we also have another kind of serological tests. Those typically use blood samples. And those are slightly different because those are most useful to see if you've had an infection in the past. So especially for incarcerated individuals, that may be relevant to figure out if someone already was exposed. That could also be relevant, for instance, if you're trying to figure out for vaccinations, if someone may already have some level of protection, or if they might need the first dose to give more protection, that kind of thing, potentially that could be useful. So the other thing I wanted to point out is, especially in the context of incarcerated and vulnerable populations, there are a couple of different ways you can collect the samples. And the one you may be very familiar with is the NP, which requires a healthcare provider. It goes really far back. It's very uncomfortable. And frankly, it doesn't really have to be done anymore. Potentially may have to be done in some circumstances, but generally speaking, there is a different kind of swab, which is AN swab or anterior nary swab, which is just like a Q-tip basically that goes into your nose. You twist it around a few times, and it's generally not invasive. It's generally not uncomfortable, especially compared to the NP swab. Saliva tests also exist. There's a little more variability in how good their results are. So generally speaking, aiming for anterior nary swab tests is what we recommend right now. There are also other tests called mid-turbinate. They use mid-turbinate swabs, and those are okay. They go a little bit further up, but they can still be self-administered. But typically the AN swabs are pretty good. So what do the tests look like? We have simple tests. We have in-case tests like the Binax Now that you all may be familiar with. We also have some much more sophisticated ones that have devices associated with them. So if you're trying to test a large population, maybe something like that might make sense. But we have a lot of different options. Right now, in terms of costs, they could be free if the government provides them for free to facilities with a subsidy. Binax Now costs the government $5 a test. And there are other tests, like some of the tests have been put on the market for home use that cost like $30 each, which is way too much. And so the problem is that a lot of the less expensive tests are being held up in the FDA queue, basically. And so groups like ours are working on advocating to change that. So I'm going to skip through these, but when we give you the slides, if you want to watch this later, this is a 2-minute video about a montage of celebrities just talking about how often they get tested, because that's why when you turn on the TV and you see people without masks, that's why, because they're all being tested behind the scenes. Okay, so I'm sorry, I didn't mean to actually start that. But it's good. And then here's a video of Dr. Michael Minna, who has been a leader since last year of trying to expand access to rapid testing. And so here's a little video of him on CNN explaining to Fareed Zakaria why this matters. It's about 7 minutes. And then here's another video. It's about 7 minutes too. It has a lot of good infographics. So just trying to explain how the tests work, especially on a population level. So I really recommend, checking these out if you want to learn more about these topics. They're really well done. So that's as far as I wanted to go with that part of the presentation. And so now I'm going to turn my attention to what we actually said in our commentary. So this is just giving you a sense of who is involved in this work. It represents the efforts of authors from all over the world, multiple continents, from multiple institutions. And we're really proud of putting this together to try to spread the word about the ideas that we have in here. So it's just giving you some context for where the authors are from. And actually, you'll notice that one of the authors listed is the Rapid Test Working Group, which represents a team of experts that we have organized at rapidtest.org, which is directed by Michael Minna, started by Dr. Chris Sade. And so basically, we put together information that's coming from different parts of the world, and that's what helped inform what we're sharing with you today. So basically, we're going to go through each of these points briefly just to give you a sense, but there are 4 reasons why it's wrong not to test, and we'll go through them one by one. So the first is that frequent rapid testing uniquely complements other infection prevention, identification, and mitigation strategies. So you might have been familiar with the Swiss cheese model. And the little mouse agrees that testing is really important. Sorry, I think that my bar here might be covering it up a little bit. It'll go away in a minute. So you need multiple layers because no one layer is perfect. And so we really need testing because in the absence of testing, it can be a lot harder to prevent and control outbreaks. So I think one of the big points we're trying to convey here is that rapid tests are one tool in the toolbox that can help really make a difference. The second big point is comparing frequent, widespread rapid antigen testing to targeted, infrequent molecular testing is a false equivalency that leads to harm. And for this point, I'd actually like to have Dr. Phoebe Alheva join us so that she can help explain what's going on here. So Phoebe, can you join us?
Sure.
Thank
yes. You. Hi. Hello, I'm Dr. Phoebe Alheva. I am a physician in Boston, and I've been working with the Rapid Tests Working Group since the end of the summer. Mostly my focus has been on working with schools to help schools reopen with testing. But I just want to go over a little bit about the testing and where we see testing helping to prevent outbreaks. So going back, yes, to this slide here. So this is a kinetics curve of the virus. So if you follow this blue line that goes steeply up and then trails off, you can see that initially the viral load peaks quite rapidly. And there's a period of time when people are infectious, and that's in that window with a high viral load. The dashed line above shows you the low analytic sensitivity, and that is referring to the rapid antigen tests that Sherry was just describing. As well as you can see a bar that's lower with the more high analytic sensitivity PCR tests. What's important to look at is the frequency here, these little circles as it comes across the screen. And you can see that with repeated frequency, you're more able to find somebody in that shorter window of when they're infectious. So we like to look at that infectious period and make sure that we're catching people during that period. Now you can do that higher level PCR test a little bit less frequently because it will need to be run at a lab. It's more expensive. The turnaround time for that is often several days. And yes, you could get more sensitivity for finding that level of virus, but you may not find that actual person during their infectious period. So in fact, that lower sensitivity rapid antigen test may actually be more helpful if you're able to repeat it more frequently. Okay, so again, this is just looking at total infections on the scale to the left, saying all the way up to 100%. If you're not testing, obviously you're not catching any of those infections. But if you're using a higher sensitivity test, you can catch infections as they go through over a longer period of time, but it's really when you're testing more frequently that the lower sensitivity test, if you're testing on a weekly basis, you can see is actually catching more of those infections than the higher sensitivity test in the pink. So that's what we're looking at here.
Wonderful. Thank you, Dr. Alheva. And so the main takeaway here too is just to say that if you're, I think one of the things that Margot and Sarah and other Corinne have brought up is that right now in prisons, they're testing maybe once every 2 weeks, and you can see what happens if you're only testing once every 2 weeks. You're basically not really able to stop outbreaks. You're not really able to stop infections. So weekly testing is better, but if you can test about twice a week or every 3 days, you're getting a much greater ability to control infections, especially in settings where people are housed close together, like in prisons. So, and we're almost done with our presentation. So I'm really looking forward to hearing your questions. Okay, so just filling around with here. Apologies. Sorry, I'm going to stop fiddling with that. Okay, so, okay. And this is the last thing we wanted to point out in this point. Go ahead, Phoebe.
Right.
Sorry.
Yeah. So I think this slide is really the key slide to understand. I know it appears busy, but just start with me at the far side here, right before where you can see the PCR test and the rapid antigen test. So here you have a group of people all together, and those folks in black are the infected individuals. Now, if you follow the PCR test across the top, you do the swab on that first day, but those folks that are infected still stay in the community for 2 more days. So you actually have 10 days of infected people being around other non infected people who may be susceptible to the virus. Now, if you do the rapid antigen test, which may be a little bit less sensitive, on that very first day, you're able to pick up 4 out of 5 of those people and immediately initiate isolation and remove them from that group of potentially susceptible people. So you follow them to the next day, and there's actually only one person who's continuing to stay in that population. And you can repeat that test. So if you repeat it again 2 days later, you may find that next one person and remove them. But at that time, you quarantine just a few people around that one infected person who has been in the mix. Whereas with the PCR tests, all those people, those 5 people, have been in that group for that period of time. So once you get those results back 2 days later, you have to look back and say, oh, where was that person over that period of time? And we need to identify them to potentially quarantine them, as well as the fact that those folks may have been actually exposed to infection and have turned up to be infected, which you can see as the sort of light brownish orange in that group. So if you look at that size of the population that you see on day 3, in the rapid antigen test group, you have one person among maybe 5 other in quarantine, where in the PCR group, yes, you've achieved identification of those initial 5 people, but you've needed to quarantine others, and your group who are already infected is also increased outward to day 4 and beyond. So I think this slide really is important to understanding how rapid, frequent testing can really stop infections and help with a population that is in a communal setting.
Excellent. Thank you so much. Great. So the last 2 points that we have to make here are, sorry, okay, here we go. The last 2 points are related to, the next one is universal access to low cost or frequent rapid tests with follow-up and support is crucial for promoting equity. And what we mean by that is that we need to have this universal access to these tests so that they can be done every couple of days or however often is needed for the particular setting. And the other really important point about this is that follow-up and support are crucial, because it's not enough to just have a positive result. It's important to do something about it, because if you don't do anything about it, those people are just going to make other people sick. So at this point too, I just wanted to briefly mention why our commentary is called "It's Wrong Not to Test." Because we did think hard about this. And this is just a line from the commentary. In the midst of a raging plague, it is inequitable and unethical not to deploy high quality rapid tests alongside existing public health interventions. And the reason why we say it's wrong not to test is we thought about saying it's right always to test. The problem with this particular statement is we actually don't believe that people should be forced to have, NP swabs, or, unless it's a last resort. People should have the ability to make choices about what happens to their bodies. And they should have choices that are humane, and that, if they want to be tested, that they should have access to it. So we do think it's right to test, but we also think that the autonomy of the individual, the dignity of the individual, needs to be respected. And so these two aren't exactly the same thing. And we're not really talking about tests, we're talking about people after all. And so the reason why we're saying it's wrong not to test is because there are lots of people saying it's right to test, but the problem is right now the testing is still being withheld or not offered to people like vulnerable populations in prisons. So the last point here is self-testing is effective. It's been used for other health conditions like pregnancy, management of HIV. There's a lot of evidence about this for other conditions. There's some emerging evidence for COVID. And, just like this, you can do this little swab. You can just have this test result within 15 minutes, and it's very empowering, and people can even swab themselves. So that's it for our presentation. So I wanted to thank you all so much for your willingness to listen, and we're happy to take questions in whatever time we have left. Thank you.